there are certain areas where EUS can actually add to the staging of the disease. And one of those areas is a
Hello,
perihepatic
hello.
ascites. So there's a small amount of perihepatic ascites which might have been missed on other cross-section imaging modalities. So there's a perihepatic ascites present or not present, number one. Number two, are there any focal hepatic lesions in
Yeah,
the left lobe?
yeah, okay, we can hear you and see you.
Okay, fine.
Nadeem.
Ji sir, let's just, shall we present the case, please?
Okay, Assalamu alaikum, sir. We have a patient, 65 years old male. He's biopsy prone, US guided biopsy prone case of adenocarcinoma of pancreas. Recently came with we had a CT scan done that is showing the mediastinal lymph nodes. So our aim is to assess the mediastinal lymph nodes, either it's metastatic or it's benign. So HB is 12.2, TLC is 19, and LFTs are total bleed is 2.8, SJPT is 98, and L4 is 150.
Okay. So Seher is going to start the procedure. Seher, just for the benefit of the delegates in the room, what we would like to do is if you could just talk us through every step along the way, please. It's okay, that's fine. Let's just, I mean.
Big wheel up so that
So tip down when you reach the posterior oropharynx, then you tip away or big wheel away from you. Good. Okay, so gently advancing. Excellent, good. So examination, whether you're doing mediastinum or pancreatobiliary examination, always or should start at the GOJ, okay, gastroesophageal junction. So keep going, keep going, keep going. Good, excellent. So at this stage, you just should make a habit of making a mental note of where the GOJ is, even if you're doing a diagnostic or therapeutic procedures. Sometime in therapeutic procedures, when you're actually draining collections, especially from the pancreatic tail region, before you realize where you are, you end up sort of, when you're adjusting your scope position, you at some time may end up being very close to the GOJ where you may actually have to puncture. So it's good to know exactly where your gastroesophageal junction is. That's number one. Number two, you want to just insufflate some air and make sure there's no hiatal hernia. Because if there's a hiatal hernia, then you're actually going to be struggle to demonstrate all those sort of basic stations. So you then have to, you may have to modify your approach as well. Good. So you're doing exactly what Dr. Hassan suggested earlier. So advancing the scope to the greater curve. Good. There's no hiatal hernia. Excellent. Keep advancing the scope, please. 1 minute रुकिएगा. Good. Excellent. And now क्या करेंगे आप? Excellent. Good. अब हमें दे दीजिएगा. EU समझ दे दीजिएगा. Good. Excellent. Good. So let's just freeze. इसको freeze कीजिएगा. Just show me the button. Because what you want to see here is, इसको मुझे वो pointer भी दे दीजिएगा, pointer भी, ठीक है? हाँ, exactly. So what you want to do is when you start this examination, you want to make sure there's no perihepatic ascites. Again, it's to do with the staging. So there's no perihepatic ascites. Other advantage is if something happens during the procedure, especially in the therapeutic procedures, and if there's any fluid or air around it, then that's where it accumulates. So you've started the procedure. There's no perihepatic ascites. It otherwise looks okay. Helps with the staging. Fine. Unfreeze कीजिएगा इसको please. Good. Okay. Now, दूसरी चीज़ ये देखें कि it's going from 0 to 8, and this bit of the screen is all it's of no use to us. Correct, exactly. So इसको reduce it to maybe 4 centimeter. Reduce the depth, please. Reduce कीजिएगा. आप बढ़ा रहे हैं. Bit more. That's good. That's fine. Excellent. That doesn't look too bad. Good. Okay. Now the second thing is, can you see any focal lesion in the liver? Good. So what you want to do is now just keep scanning the liver and see if you see, what else do you see? Have you?
dilated duct.
Fantastic. Excellent. So the intrahepatic ducts remain dilated, no perihepatic ascites, no focal lesions so far. Yeah, good. Excellent. So you're improving your coupling, you're ensuring there's no air. Good. Excellent. Can you see, can you appreciate any pneumo?
Would you use your Doppler at all?
इसको पॉइंटर हटा दीजिएगा.
मैं कह रहा हूँ
Some of the ducts have
Nadeem?
whitish.
Yeah, exactly. Absolutely.
Can you hear me?
जी sir.
आप Doppler use करेंगे?
Let's have a Doppler.
Thank you.
Yeah. Good, yes, please. So the intrahepatic ducts are still dilated, which is not a bit of a surprise. I think the ERSP was a bit recent. Minimal pneumobilia, which is keeping in with presence of the biliary stent. Good, okay.
The aorta now?
You can, but obviously you can, in the same time, you can scan the plane and just slowly rotate. So if you're not going to go from the patient's right to the posterior, okay, good. So clockwise rotation, good. So the other thing, I'll stop you there. Okay, exactly. So just remember, you need to step back a bit. Make sure every movement that you're making here, you're able to transmit exactly. Fantastic. So keep it as straight as possible with the right hand. Good. Very nice. So go back to your image where you had earlier. Good. Very nice. Withdraw the scope ever so slightly. We want to see if go back to the liver again. Good. Withdraw the scope. Withdraw the scope. Remember, getting 2/3 of the scope onto the right and 1/3 here. We need to get more hepatic parenchyma. A lot of central intrahepatic ductal dilatation. Suction, suction, suction. Tip up, please. Tip up, please. Tip up, please. Good. Very good. Tip up. Still good, good, good. Excellent. So withdraw ever so slightly further. Bit more. Throw all withdraw करें. Throw all withdraw करें. Good. ये air से get rid of this air. Tip up. Want to make sure the 2/3 of the good. Better. Fantastic. Very good. Keep going, keep going, keep going. Good. Now what you want to do is go posterior and you want to move your probe back. So इस हैंड को ना इस हाथ से एक आपने जो चीज़ करनी है ना इस हैंड से ये फिंगर सिर्फ सपोर्ट करेंगे इस स्कोप को ठीक है ना द पर्पस ऑफ द राइट हैंड ऑफ द फिंगर्स इज टू लिटरली जस्ट सपोर्ट द स्कोप यू आर नॉट होल्डिंग द स्कोप यू आर नॉट डूइंग टॉकिंग यू आर नॉट डूइंग एनीथिंग द ओनली पर्पस इज आइदर वेदर यू एडवांसिंग द स्कोप और यू विड्रॉइंग इट अदरवाइज ऑल दीज फिंगर्स आर डूइंग इज जस्ट सपोर्टिंग द स्कोप गुड एक्सीलेंट now just keep going to the right 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 right
और पुल करो
अच्छा अब हुआ क्या देखें इस वक्त आपकी जो नहीं इसको यहीं रखें एग्जैक्टली और दूसरा ये हुआ है कि देखें लेट मी टेक ओवर दिस फॉर मी अच्छा सेम चीज़ अगेन majority of the liver is on this side I've got a maximum view all I'm doing with my right hand is supporting I'm going to go this if this doesn't work I'm going to rotate all the way to the right what has happened obviously I've landed up possibly onto the gas already there let me just see if I can go back and there's the aorta ठीक है ना now my scope is pretty relaxed और यहाँ पे even it's free my right hand is already free ठीक है so you move your shoulders first and then because होता ये कि if you move this way you're already in a bit of a tricky position okay so let's just see if we can go back let's see if we can reproduce that image so the left lobe suction tip up good थोड़ा सा इसको reduce कर दीजिएगा keep going to the right good very nice good well done excellent so celiac axis diaphragm crust good okay what are you going to do next
push a bit
जी बिल्कुल so SMA and celiac axis yeah, okay good point to दीजिएगा डॉक्टर साहब को और yeah
celiac take off and this is the spear
good
so I'm going to follow the celiac
जी बिल्कुल अच्छा एक और चीज़ आप इस स्टेज पे दे सकती हैं रिमेंबर our question that's being asked is about the mediastinal nodes are there any further lymph nodes around the celiac any periceliac nodes okay नहीं exactly then there is nothing out there's nothing jumping out ठीक है ना अच्छा उसको व्यू को there are some small but I don't know the tiny ones are they related or not okay so just advance the scope there should be no resistance there should be smoothly you should be able to advance it are you able to advance it G, good. Keep advancing. Splenic vessels coming in. Good. Keep advancing. Good. Towards you.
this is the pancreas
We'll find out soon. Why is there resistance? Why are we actually getting some mucosa hung up against the tip of the scope?
maybe theater करनी no but we didn't see anything
We didn't appreciate anything, did we?
okay because degree is very so much
Yeah.
is the reason okay
So जो right hand है इसको let go. Just let go the scope with the right hand. Good. Excellent. Move your shoulders. Good. To the right. Very nice. इस पे Doppler दीजिएगा. Doppler किधर? Good.
This is the
So,
pancreatic duct.
good.
It is dilated.
Very good. इसको थोड़ा सा इसको ऑफ कीजिएगा Doppler को. इसको इंक्रीज कीजिएगा. डेप्थ को रिड्यूस कर दीजिए. सॉरी. और एक सॉरी.
कम करना है, बढ़ाओ यार.
गुड. इसको अब फ्रीज करेंगे. तो इसको मेजर कर लीजिए. Why are we not seeing the pancreatic parenchyma? कितना है ये? Good.
Yeah, because it is too much dilated, no? Double sided.
नहीं, उसकी वजह ये है कि जो pancreatic parenchyma, there is an atrophy of the pancreatic parenchyma in a chronic. Good, excellent. So exactly. So in a chronic obstructive process, you'd expect atrophy of the pancreatic parenchyma. PD is dilated. Now see if you can just trace it all the way back to the body of the gland and then the tail of the gland.
So, can you point out the structures there, Nadeem? Because
So,
to me,
Clockwise
so
rotation,
you have
please.
two vessels here.
Clockwise.
I think they are asking something.
Ji.
Artery or vein है.
Good. Okay, so let's just go back. Where's the pointer?
Here.
Nadeem, can you just
Ji.
use the Doppler?
Good. So splenic artery.
And the vein.
Can we use the
Splenic vein.
Doppler?
Good. Where's the Doppler?
Yeah. And this one is the pancreatic.
So, artery, vein,
Okay.
pancreatic.
So splenic artery, splenic vein, PD, dilated PD.
Normally, I do is when I do the clockwise rotation from here,
Ji.
I land up in aorta again.
No, you shouldn't. You shouldn't. No, don't. You'll be fine. You'll be absolutely, because those two structures are close by. But if you just keep that in the center of the screen, इसको Doppler निकाल दीजिएगा. Keep that in center of the screen and just see if you can just go clockwise. So you don't need to actually move the scope. Good. But you do, if you lose your image, you go back. You undo what you've done. Yes, good. And now, in order, again, if it's moving away from you, you may need to advance the scope a bit. You know, so movements, advance the scope, withdraw the scope, tip up, tip down, those are the things that you can do. So just keep it in the center of the screen, good coupling, no air insufflation, and keep it in the center, and then just gently rotate clockwise. Good. And if you start to lose it, you may want to advance the scope. Good, very good. Keep going, keep going, keep going, keep going, keep going, keep going, keep going. Very nice. Keep going, keep going, keep going. Clockwise, keep going. Suction as well. Keep going. You're losing. Good. So if you lose the image, you undo it. You go back where you were before. Good. That's enough. Okay. Keep going. Keep going. Keep going. Keep going. Keep going. Gee, it is significantly dilated again in keeping with the obstructive process. So keep going. Keep going. Keep going.
Kidney coming down?
Uh,
Oh, not yet.
no, that's fine. That's fine. That's okay. Obviously. Yeah. Yep. It's fine. Tip up, and if you can rotate all the way to your right. So sometimes if you lose it, again you're excellent. So you're seeing spleen. Excellent. So that means is that if there's anything in the pancreatic tail, it's unlikely if you've done a sweep and you've gone all the way to the spleen. Good. So if you've seen the spleen, the kidney is literally right next to it. So focus on the spleen. See if you can see in the splenic hilum. The significantly dilated PD with some multifocal side branch dilatation. Good, excellent. And now the left kidney should be right next to it. So
कम कर दें इसकी तरह ना, ताकि स्क्रीन में पूरा हो.
that's it. Yeah, that's fine.
वापस
G. Gently. And the moment you lose it, you're back on the pancreas. Very nice. That's good. So keep scanning. So in the scanning in the same plane. That probably. So again, undo it. Go back. I think you just briefly saw the kidney there.
This is the last part we can see, or
No, no. So that's fine. I think you've said exactly. You've gone back to the aorta with the celiac and the SMA. So let's just go back again to the neck of the pancreas where you before. So focus on the right neck. Yeah, good, good, good. Follow it toward the neck of the gland. So either you can follow it or you can look at the splenic vein and see if when it joins the portal vein conference. So what are you seeing here? Let me just freeze there. Um, what did you saw there? इसको थोड़ा सा पीछे कीजिएगा भाई. We briefly saw stent in the. We had a look at the 15 minutes lege. Oh, okay, sorry. Okay, let's just quickly, in that case, we'll go to the D1. हाँ इसको unfreeze कर दीजिए. We just had a brief look at the PD stand. That's fine. Let's just go into the D1 then. Endoscopic image बड़ी कर दीजिएगा, please. Tip up, tip up, tip up. Nice. Let's have a look. Oh no, I agree. I think there is a bit of a resistance. The neck throw forward कीजिएगा. Good. Yeah, no, I think it is. There was a slight. So remember, as Dr. Hassan said this morning, so sometime what you have to do is you have to use a small wheel to the right just to align it. And it should land.
Yeah, you're on the front. But it is, bit narrow.
Yeah, I think it's just the position. So that's it. So if I should not be sort of forcing my way in. It should go in nicely. That's it. Okay, we've gone further than what we intended to, but what we can do is we can just do D2 examination. So let me give the score back to you. So suction as much air as possible. ये EUS image बड़ा कर दीजिएगा please.
Shorten कर लिया?
जी मैंने कर लिया. थोड़ा सा देख लीजिए how much scope do we have?
Still we need.
You can do a bit more, yeah, bit more. Good, excellent.
ज़्यादा नहीं बचा रहे?
That's fine. So you've just had a view of the right kidney there.
But I think it has fallen back.
So it's fine. That's okay. That's fine. I mean, it happens, especially if you're not using if I mean, I don't tend to use the balloon. So if you're using it without balloon, and when you're shortening the scope from D2, there's always a risk of scope falling back. So it should not be of a major concern. Very nice. Good. So small wheel to the right. Good. You can stay there. I think you're just in the.
Definitely some obstruction.
Good. So what do you see? Just sort of maybe you can stay here and then just sort of.
Okay.
What do you see?
Probably a vessel. And this one is, I think, CBD.
Good. Excellent. So, and the CBD with the stent in. Good. Yeah. Yeah. Please. Yeah. So
This is portal vein.
good. Portal vein and then the CBD with the stent in situ. And then obviously surrounding the stent there's a lot of debris. G, score kar dijiyega. Where's the pointer gone? Pointer. Exactly. So yeah, all this is a sludge with a stent in situ. Okay. So what you can do is you can just follow it clockwise to the ampulla.
Okay. If we go clockwise, we will
You should
the ampulla.
You should, yes. And if you go anti-clockwise, you're going to go toward the liver hilum. Yes. Good, good, good. Keep going. Keep going, keep going, keep going. Very nice. Good. Keep maintaining your views. Keep maintaining your...
Pull or push?
No, no, no. You don't need to pull or push at this stage. Unless it moves away from you, then you may have to do it. So this is, you end up on the area of abnormality, the mass lesion that we know already. Yeah. Okay. We know that one.
वाइट शेडो आ रहा है, ये स्टेन का है ना बॉस?
Uh,
स्टेन का शेडो आ रहा है.
yeah, exactly. Yeah. Clockwise, 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 clockwise.
That mass seems to come from this side.
Yeah, no, no, I mean the abnormality. So sometimes because of the distortion, you may not get it in the same plane as you were expecting it. Yeah. So why don't you see if you can go to the D2 and then we'll start taking the scope out. How much time do we have? Okay. That's okay. Then you push. Tip up, tip up, up. Yeah, tip up कीजिएगा. Big wheel towards you. Yeah, good. Advance the scope and slowly shorten, slowly, slowly. Good. That's it. That's it. That's it. So if you have, in the previous occasion, because you fell back, so I wouldn't take it all the way out. I'll just suction it and then slowly start to withdraw under the, echo-endoscopic view, rather than endoscopic view alone. And you remember that our target is to identify sliding aorta. So don't insufflate any air. I wouldn't withdraw it under endoscopic view. I'll just withdraw it under EUS view. So clockwise, clockwise. Get rid of all the air in, and your aim is to identify aorta. So suction, suction, suction. That's fine. Yes, and don't pull very slowly. Small, small, small steps. Small steps. Acha, okay, that's fine. So let's just, I'll give you, no, that's fine. I'll give you 1 more minute if you can just find out the aorta.
I will pull it back.
Yep.
The rope will not fall back.
Yeah, withdraw, 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 withdraw. Clockwise, keep clockwise, keep clockwise, keep clockwise. Okay, don't worry, that's fine. Let me just have a look.
Came back.
It's absolutely fine. This is the area of abnormality. Okay, so suction. So sometimes having a balloon actually helps because at least at this stage what you can do is you can inflate it and it actually prevents scope falling back. What's the pani dijega, water dijega? Just give me a little bit of a... I think it's working, obviously, because you've got too much air in, so that's fine. I think it happens. And obviously, every time we're trying to intubate, we end up putting more air in, and that's what can cause problem. But that's fine. Should be okay. We're using CO2, aren't we? Akram bhai, are we? हाँ जी 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 बिल्कुल. It's okay. I've just taken the button off. suction button. Okay, good. नवा बटन दे दो प्लीज. हाँ जी, thank you. Good, thank you. That's much better. Okay, so slowly withdrawing, withdrawing, withdrawing. Neji, we're just focusing. I think we're falling back in again. It's fine. It's fine. I mean, you know, it just happened. That's absolutely fine. It's see, slowly withdraw. That's always a possibility. So you start to see the pancreatic parenchyma at that stage there. And you know I'm compressing the IVC as you see it there. So this, because I'm trying to overcompensate. We didn't want to sort of fall back in again. I think the, is for Doppler दीजिएगा please. So you start seeing the stent there. Okay. So it's the distal end of the CBD. Okay. So I know I'm in the right ballpark. I know this is IVC. Good. And the aorta seems compressed. This is the right kidney there. That's it. Get rid of it. So I'm pretty sure this is the uncinate process, but obviously what we want to do is if we can just bring it back and see the mesenteric vessel so that we can convince ourselves. So mesenteric vessels, so supramesenteric vein and supramesenteric artery. I'm falling back, yes. But I think just again in the interest of time, so we'll go to the mediastinum. मुझे दीजिएगा gauze piece दीजिएगा. So all I want to do is I just want to come back. We've seen this before. Come to the IVC. तो इसी डेप्थ रिड्यूस कर दीजिएगा प्लीज. हाँ जी, थोड़ा सा और कम कर दीजिएगा. सो लेफ्ट एट्रियम, लेफ्ट वेंट्रिकल, एओर्टा एंड पल्मोनरी आर्टरी. ओके, सो फ्रीज कीजिएगा इसको, जस्ट फ्रीज इट. ओके, सो लेफ्ट एट्रियम, लेफ्ट वेंट्रिकल, पल्मोनरी आर्टरी ऑन द टॉप एंड एओर्टा ऑन द राइट. अनफ्रीज प्लीज. Left atrium, left ventricle. Yep. Aorta, good. Excellent. Do we have some mediastinal loads? So there are some nodal structures there. Yep, but they don't. It's got a fatty hilum, and it's not hypoechoic, it's not round, it is elliptical, it may be enlarged, but it's freeze कीजिएगा. But in the short axis, it doesn't appear to be dilated. Maybe a couple nodes together, it's possible, but they don't appear to me malignant, at least on this EUS image.
Because the center is hyperactive.
Well, we can see the central, so there's the hilum is fatty, The lymph nodes are sort of elliptical. It's sort of short, 7 millimeter in the short axis, and there are at least 2-3 lymph nodes together. So I, they're not on the EUS image. It's they're not involved. So 30. So I personally don't think they're involved. I personally don't think they need to be sampled based on these appearances. Are we audible in the room? Hmm? They're benign appearing, so I personally don't think we need to do the sampling. Let go, please. जाने दीजिएगा. So trachea coming together. There's this common area coming out from the aorta. There it is. So there's a aortopulmonary window there, and there's a node. It's a quite small node again. Exactly. So again, this node is not. इसको freeze कीजिएगा, थोड़ा सा पीछे ले जाइएगा, move it back. So this node again is an elliptical node, and it doesn't seem to be. It's again exactly 5-6 millimeter. So I think there are definitely nodes, metastatic nodes, but none of them are malignant appearing. So we wouldn't sample those, and I don't think there's any indication for us to do that. There's certain other lymph nodes as well, but none of them. So in the AP window, definitely not malignant nodes.
Sign out, please. Sign out, please.
Sign out patient in Mohammed Umar.